Welcome everybody. Welcome everybody to today's sessions of seminar series from Discourse and Psychosis. I want to just to introduce our presenters today and our discussants and the topics that we're going to talk about today. So introducing to the Discourse Initiative, we had more than hundreds registered members in this diverse international scientific consortium for thought, language, and communication research in psychosis. And it's an honor to keep receiving researchers to be a member in our community. We focused on the steering committee that it's very international, as you can see, with Dr. Fmri from Turkey, Eric Tan from Australia, Gina Kuchtenberg from United States, Iris Sommer from Netherlands, Lena Palaniyappan, that will be our discussant today, from Canada, Maria Francisca Alonso, part on Canada, but she's also from University of Valparaiso in Chile. I'm Natalia Mota from Brazil, from the Federal University of Rio de Janeiro, and Wolfram Hinsey from Spain. So I'm glad to announce to you that we had two symposiums accepted on the SEERS meeting for actually, that's wrong, it's 2022, sorry. And we are going to talk about these advances on the knowledge through international collaborations and trying to match all this discussion that we are having here to better understand the linguistic roots linked to psychosis, and also to talk about some therapeutical strategies on thought and language dysfunction in psychosis. It will be a very exciting moment to meet all in person. So to talk about this seminar series, we had already a talk about phenomenology and clinical aspects with Dr. Peter Lido, computational linguistics with Dr. Shara Corcoran and Guillermo Secchi from IBM. And the previous one was about data banking with the, Professor Brian McWhinney. So if you are interested, we have those sessions recorded, and you can also download the videos and watch it if you miss it. Today, we're going to talk about neuroimage with Professor Thilo Kircher, and Professor Lena Palaniyappan will be our discussant. Okay, the seminar structure will be a talk of 45 to 50 minutes, followed by a discussion of 15 minutes led by Dr. Lena Palaniyappan that will raise some issues at hand. And then we'll have the open discussion. Please feel free to use your chat box. We are going to moderate our the questions, and also you can ask to speak online as well. The event, as you know, will be recorded, so feel free to afterwards to have access to the videos. Okay, Professor Dr. Thilo Kircher, he's a professor of psychiatry and psychotherapy on Philipps University, Marburg in Germany. After his PhD in neurology in Tübingen University, he performed a postdoctoral training at the Institute of Psychiatry in King's College in London. He was a professor at the School of Medicine and University Aachen, Germany, and currently at the Philipps University, Marburg in Germany. He's interested in research the etiology of mental disorders, particularly psychosis and affective disorders, doing brain image of cognition, emotion, communication, and social interaction in healthy and patients with mental disorder, as well in improving therapy and psychiatric disorders, particularly psycho and pharmacotherapy, neuroplasticity, and the effects of therapy on that. He had published hundreds of peer-reviewed articles, awarded and recognized nationally and internationally, and has contributed to the understanding of the neurobiology of motor disorders and psychosis. Our discussant will be Dr. Lena Palaniyappan, as some of you know him already. He works with patients and families experiencing psychosis. He holds the Dti Studies Chair in Neuroscience and Mental Health at the Western University and Scientific Director of the Prevention and Early Intervention in Psychosis Program, London, Ontario, Canada. He leads the Neuroimage in Mental Illness Research Group based at the Robots Research Institute at London, Ontario, Canada. Following his bachelor's degrees in psychology, he completed his MD at Stanley Medical College, India, followed by master's and PhD in translational neuroimage in the University of Nottingham, UK, with Professor Peter Little. He received many prestigious grants and awards, including awards from Royal College of Psychiatrists and the Canadian College of Neuropharmacology, and also the Global Rising Star Award from SEARS, the Schizophrenia Research Society. So it will be a great joy to listen to you. I will move to my microphone now, and please, and stop the sharing. And please, Dr. Chilo, it's with you now.
Yes, Natalia, thanks very much for your introduction. And thanks to Lena, to you, Natalia, and to the committee, the Discourse committee, for inviting me, for giving this presentation. I'm very, very honored to participate here. And I want to thank Lena and the Discourse committee very much for setting up this fantastic worldwide initiative on thought and language and communication disorder. I think this is just what the community needed, and I'm really very, very happy that you are organizing this. This is really wonderful. Let me start with my presentation and sharing my screen here. So can you see my screen now? Yes, okay, fantastic. Since we are a worldwide community and people are sitting now on many different continents, I would like to start showing you where I'm based now. This is the world. Marburg is here at the center of Europe, basically, at the center of Germany, in fact. It's a very old university town, founded in the town is much older, but the university was founded in 1527. And it's in fact the oldest non-Catholic university in the Western Hemisphere. Because it's so old, there were a lot of famous people coming from that. For example, the first Nobel Prize in medicine from Emil von Behring for vaccines. In fact, in Germany, in Marburg, the biotech vaccines are being produced for, well, at least Europe, I think, and many other countries. So this is Marburg. It has a castle here, a river, nice medieval town center. It has 80,000 inhabitants, 25,000 of them are students. So basically there's the university and the pharmaceutical company making, well, medical products. So it's very nice to do academic work and raise a family here. And if you happen to come to Germany, drop by. But now, switch to science, neuroimaging, and form of thought disorder. I want to start with two MRI studies to lay the ground, basically. The first one is from Martha Shenton from 1992 from the New England Journal of Medicine. And she was the first one to show that the volume in patients with schizophrenia of the left posterior superior temporal gyrus correlates negative with the amount of thought disorder with the Holtzmann scale. So the more thought disorder the patient was, the smaller was the temporal lobe on the left side. So there was a reversal of the superior temporal gyrus volume in patients. Normally the left is larger than the right. In the patient, it's about the same, left and right. And it's not only the superior temporal gyrus, it is also they found differences in the hippocampal, in the hippocampal area. The other study is from ourselves, together with Peter Little, who also presented here, and Phil McGuire from London. What we did in this Fmri study is we had patients, selected patients with high amount of positive form of thought disorder. The Fmri. Oh, can we turn off the microphones? Okay, fantastic, thanks. So we put them in the scanner. Patients were talking continuously in the scanner. We recorded what they said and analyzed the amount of thought disorder in 20-second epochs with Peter Little's TLI scale, and then correlated the bald effect across time with the fluctuating amount of form of thought disorder. And what we found is that in the superior temporal gyrus here in blue, this was deactivated, this area, the higher the amount of form of thought disorder was in the patients. This is a part of Wernicke's speech area again. And this is a study that came out 3 years earlier from some of the same authors who did sort of the same thing, but with PET, with water PET. They found basically exactly the same. The amount of positive form of thought disorder correlated negatively here in the superior temporal gyrus in their patients. So this area here is the same as this one here. And this is very striking because this is PET and the other study was with fMRI. Patients are different. The analysis software is very different. And the results are, well, totally matching. There is also a positive correlation here, which is very similar to this positive correlation here in red here. The difference really is here in parts of Broca's area that was found in the PET study, but that we did not find here in our fMRI study. And I think this is due to susceptibility artifacts due to speaking in the scanner. So we didn't correct for that. And with PET, you don't have this problem. So to conclude from these studies, Broca's and Lang and Wernicke's area, but also areas on the right hemisphere are implicated in form of thought disorder, positive form of thought disorder. And this really sets the stage for what I'm going to tell you in the next, 45 minutes. This is an outline. I will very briefly start with psychopathology, then I'll talk about brain imaging, the glutamatergic system, and then show you findings from other diagnoses other than schizophrenia. So let's start with psychopathology. If we do brain imaging in patients with form of thought disorder, we have to describe them, and that's why we need a proper tool to do that. We developed one, published in Schizophrenia Research in 2014, called Thought and Language Disorder Scale, the TALD. It's being available in English, in German, and validated in Turkish, but also in other languages, Italian, Spanish, Mandarin. And it's published in these languages also, but not validated in these 3 languages. If you go to the end of the paper, it's open access. In fact, there is an appendix. It's a bit difficult to find, and you can download the English and the German scales here from this web page, and also some other supplementary information. It has about, this TAL scale has about 30 items, which can be cut down to 4 factors: an objective and a subjective factor, and positive form of thought disorder and negative form of thought disorder. And we validated this in schizophrenia, bipolar disorder, major depression, and healthy control subjects. And I just want to draw your attention to one factor, that's the objective positive factor here. That's present, of course, in schizophrenia, but even more present in mania and also in patients with depression. And in the end of my presentation, I will show you that the areas implicated in positive form of thought disorder and schizophrenia aren't specific to schizophrenia, but are the same in mania and major depression. So what I'm saying for schizophrenia holds also true, I think, for other diagnoses. So it's unspecific. But let's start with schizophrenia first, because this is where all the papers are being published. So I'm going to talk about, I have been talking about phenomenology, just to introduce the TALD scale. It's a classical psychopathological scale. We want to talk about brain imaging, but also about receptors and the neural system, and then very briefly about genetics, and really try and come up with a pathogenesis of form of thought disorder, positive form of thought disorder. And this is what I'm focusing on today, positive form of thought disorder. So now, brain imaging. And we're looking at the brain areas related to positive form of thought disorder. There have been a couple of fantastic reviews or meta-analysis in the last 4 years, basically. One by the Byrne Group and ourselves, with Gavelti as the first author. 2 other fantastic reviews by Philip Sumner and Susan Rossell from Australia. A smaller one on purely Fmri studies. This is from Germany also, and a review by ourselves in Lancet Psychiatry from 3 years ago. So if we look at the areas that came out in these reviews as being related to thought disorder, it's these ones here depicted in color. This is an image from the Gavelti, from our paper, but it's there's also a very nice image in the Sumner paper. So what are these areas being implicated in positive form of thought disorder? It's the superior temporal gyrus, the middle temporal gyrus, parietal lobe, inferior parietal lobe, and inferior frontal gyrus. Part of Broca's area. Here is Wernicke's speech areas, and also the fiber tracts connecting these areas. Particular, the arcuate fascicle here in this one, it's the violet one, the uncinate fascicle, the red one, and the large fiber bundles connecting the frontal with the parietal lobe. Here the superior longitudinal fascicle and the inferior fronto-occipital parietal fascicle. So this is the left half of the brain, but also the right hemisphere is heavily involved in form of thought disorder. So I just mirrored this image here to give you an impression. It's not only the cortical areas, but also subcortical areas, such as the hippocampal formation, the cerebellum, and the corpus callosum. There is a nice table in the Philip Sumner review giving evidence for these subcortical areas here. So what I'm going to tell you now is that really it depends on the patients you look at, the psychopathology the patients have, the method you apply, and the cognitive task, if you use fMRI, the cognitive task you use. So on these four variables, it depends on which of these areas are being activated or deactivated or being smaller or larger in patients. This is sort of the bottom line that I'm going to tell you. So let's look a little bit into more detail into these areas. This shows you the findings in structural MRI studies. This is from the Caverti paper, with here the different brain areas, and on the y-axis the number of studies that have found something or nothing in these areas. And in the light gray shows you the number of studies, 12 here in fact, who found an association between the left STG and form of thought disorder, and the light gray who didn't find anything here, that's 9. So what you can see here, that the left STG and the right STG, and also here, the right inferior frontal areas have been repeatedly found to be implicated in structural MRI studies of form of thought disorder. So I've shown you this study here. This is the first one from Martha Shenton, seminal study. But there are, of course, others, such as this one from the Bern group by Horn, who showed that here there is a correlation between the negative correlation of form of thought disorder with the cortical thickness here in the right temporal lobe. Then we move on to DTI studies. There are much less DTI studies. So there is less consistent finding on them. This is a study from us where we found a negative correlation between positive form of thought disorder and the cingulate bundle here in patients with schizophrenia using the SAPS. And we also looked at other factors, but they are not important now. And this is a nice study from very recently, from last year, from Zurich and Bern in Switzerland. The nice thing is that they analyzed one group of patients and then replicated their finding in a completely different group of subjects from another site, which is very unusual in this area. And what they found is again a negative correlation between, well, here's semantic processing and these fiber bundles here depicted in color. It's in red, the inferior fronto-occipital fasciculus, here this one. In blue, the inferior longitudinal fasciculus connecting the frontal and the temporal lobe, and then the uncinate fascicle here in green. So that's the ones I showed you in the schematic figure in the beginning. So that were DTI studies. And I move on to Fmri studies that you can distinguish depending on the methodology into those using a symptom catching approach, those using a task-based paradigms, cognitive or linguistic task, those with resting state, and those using computer linguistics. And then I'll show you just one or two brief examples of these each. But first, look at the summary statistics. Again, this is the same approach. Down here, you see the different brain regions. Up here, you see the number of studies. And this is from Philip Summers' review. Here, in light gray, you have no significant relationships. With medium gray, here you have a hyperactivation, and in dark gray you have hypoactivation in these areas. And again, I said this is a number of studies. So where is some signal here? There is some signal here. Again, left and right lateral temporal cortex with hypo and hyper activations. As I said, just depending on the task you use and the patients you look at. Then there's some signal here. That's the left and right cuneus and the cingulate cortex. And there is quite a lot of signal here, around here. And that's the temporal lobe. Again, left and right-sided language areas in the lateral prefrontal cortex, in the lateral temporal cortex, in the cuneus, in the cingulate cortex, and there is also something going on in cerebellum and in the subcortical areas also. So what we could do now is try and disentangle why there are these hyper and hypo and non-activations, but I'm not going to do that because there is just no time. This would be a different presentation then. I'll give you some examples. So these are examples I showed you already with the symptom catching approach. Is when patients lie in the scanner, they produce speech and language, and then while they speak, you correlate the activations or deactivations just depending on your linguistic or psychopathological analysis. You can draw this to the limits, as I did here some years ago. Here I used the same data from here, but I didn't look at the overall amount of thought disorder, but only at peculiar words or neologisms from Peter Little's TLI scale. And I just picked out these words and used the continuous speech as baseline and used these peculiar words as events and had a look at what happens during these peculiar words in an event-related design while patients are speaking in the scanner. And amazingly enough, what this data shows is that during peculiar words, the right lateral temporal cortex is being more activated than during normal speech, and the left anterior cingulate cortex. So there's a reverse lateralization of the semantic lexicon. Usually we use the right semantic lexicon, but during peculiar words, the patients activate the right semantic lexicon with wide semantic field, so they pick the wrong word. So semantic lexicon is something, wrong, and here the anterior cingulate is executive function. Obviously, the cognitive resources are being allocated at the wrong brain areas, and there is also something going on in the cerebellum. This is being published. I was, well, not wise really, in a German book. So nobody is reading or citing this. But if you want to know this, I've translated this into English. So you just write me an email and I'll send you the chapter here in the book where it's being described in English. But you can quote it, and it's in German. Anyway, I skipped that. We did well, just a study, so that the hippocampus here is also implicated in form of thought disorder. Yeah, there's another study of ours just very recently where we used the same approach, people speaking in the scanner. I think this should be used more often. I think it's very interesting and very well, resourceful data you get when you have people speaking naturally in the scanner and use this data for your analysis. So these were symptom catching approach. This was the task-based approaches I was just touching at. And this is a resting state study, again from Switzerland. They correlated the severity of form of thought disorder with resting state activity and found right and left superior temporal gyrus correlation with the form of thought disorder and during resting state. And then there is these very exciting studies. I think this was the first one from Correlates in 2014 from Britta Elevok's group. And there is also a very nice one from Lina's group. And what they showed is they analyzed the natural speech using automated speech processing, and then correlated the results from this automatic analysis with brain connectivity, and found a positive correlation here in Lina's studies. And they also found a correlation of the speech connected variable with thought disorder and with cognitive performance, similar to what in this study by Britta Elevok was found. And again, you see speech areas here and here. And I think this is very, very exciting data, and I think it's a very exciting approach. And I think this moves really the field forward, and this should be done more often. Due to time constraints, I can't go into detail into these, I think, very, very exciting findings. Yes, so since we don't have much time, this really sums up what these many studies, depending on how you choose them, between 60 and 90 studies. A language network on the left hemisphere and the contralateral language network on the right hemisphere, and other subcortical areas. I've shown you the hippocampus, cerebellum are being implicated in form of thought disorder. And just depending on the patients you choose, on the symptomatology of the patients you look at, on the task you look at, on the analysis method you look at, you find, well, different activations and deactivations, hyperactivations, smaller and larger cortical volume in these areas. And this would be one way to move the field forward, to disentangle what are really, which variable you have to use and tweak in order to describe this in more detail. So it looks as if the findings are very heterogeneous with these hyper and hypoactivations, but it's really not heterogeneous, the results, but it depends on what I've just said on these variables. And if you look very carefully at the methodology of these different studies that are out there, you will find quite a lot of consistency, really. So these are the factors, the variables that are related to speech and language. And then there are also these findings, of course, that add up to real heterogeneity, small samples that are being used in the field. Depends on what method you use. And well, there are errors and false positives and false negatives, as in every study, really. But I think that the important thing is this here, up here, these four points that we have to look at more closely. So we know the areas that are implicated in form of thought disorder. We know them quite well, and there is quite a lot of consistency. But I think what's really, really important and interesting now is the pathophysiology. So why are they different in the patients from control subjects? What is the etiology in terms of genes and environment, and in terms of what's going on a molecular and cellular level? And I will talk about that just for a couple of minutes, and I will focus on the glutamatergic system. This is a glutamatergic synapse. This is the glutamate being released here, and it docks on the NMDA receptors, among others. And what we can do, we can block the NMDA receptor with the anesthetic ketamine. And when we block this receptor in healthy control subjects, we can induce positive and negative form of thought disorder in our healthy control subjects. And this is in fact what we have been doing in several studies. We have put healthy subjects in the MRI scanner, let them talk continuously, again the same symptom catching approach. And on one occasion we gave them placebo, and about 2 weeks later we gave them ketamine, of course in a crossed design. And then we correlated the amounts of words per 20-second epoch with the bold effect, and subtracted the ketamine from the placebo condition in healthy subjects. And what we found is during the placebo condition, our healthy subjects, they use, here in green, they use for the producing continuous fluent speech. They don't use the left, but they use the right temporal lobe. The right temporal lobe with the wide semantic fields, and this is why they produce positive form of thought disorder during the ketamine infusion. And what struck us very strongly is that this activation here during ketamine is exactly, well, pretty much, it's not exactly, but it's pretty much the same area that in another study that used the same methodology, having patients with schizophrenia and very prominent positive form of thought disorder lying in the scanner, speaking fluently. We correlated the amount of words spoken per 20 seconds with the bold effect. Here in blue in the patients on the right, in the right temporal lobe, very similar to this area in the ketamine infusion, very different from the healthy controlled subject that used to use their left temporal lobe for speaking. So basically, patients with schizophrenia, positive form of thought disorder, use their right temporal lobe when they speak continuously, using the wrong hemisphere, using the their semantic lexicon with the wide semantic fields. And this is the same as we found with our ketamine study. And this is why I'm pretty much convinced that formal thought disorder has something to do with, well, the right temporal lobe and with the glutamatergic system. And this reversed lateralization during speaking in the patients that we also found during ketamine in the patients is a very old idea from this colleague of ours. This is Wilhelm Griesinger, who was a German psychiatrist and who said about 150 years ago, he said, perhaps deficient reciprocal action of the two halves of the brain may have influence in producing incoherence. And this is what is being shown here. So this is a very old idea. And basically, down here, this is what I want to tell you, that the rarefication of synapses in the glutamatergic system in the superior temporal gyrus and probably other regions are implicated in formal thought disorder. These other regions come, among others, from Lena's group, who did a spectroscopy study showing that there is a glutamatergic problem, I would say, in the cingulate cortex. And I'm not going into detail here because all this is being summarized in our Lancet Psychiatry review 2018, where I used mismatch negativity studies in humans and in monkeys, and in humans again in Fmri and MEG in our study to really convince you that the glutamatergic system is involved here. And this is the bottom line, really. This is a schematic section of the cortex with layer 1 to 4. There are 2 more layers, 5 and 6, which are not depicted here, of the cortex of the superior temporal gyrus. These gray ones are the pyramidal cells. These are the brown ones are GABAergic interneurons. And what you can do with ketamine is block these glutamatergic transmission here. And in schizophrenia, you have a rarefication of synapses here. And this disrupts this circuit here in the superior temporal gyrus, which, for example, in ERP studies produces the N1 or the mismatch negativity. And I think this is the cellular basis of synaptic rarefication in schizophrenia, where you have the smaller cortex in the STG. And the reason why we have reduced mismatch negativity in the temporal cortex here in the patients and during ketamine infusion, and why we have disactivation in the superior temporal gyrus during language production in patients with schizophrenia and in healthy control subjects. So again, I refer you to this article where this is outlined in more detail. So I talked about the glutamate system, but we also know, of course, that the dopaminergic system must be implicated somehow in formal thought disorder, because if we give our patients who are unmedicated, if we give them antipsychotics, usually within days, positive thought disorder is much better usually. But we also know that there are GABAergic interneurons, and I know from unpublished data that the acetylcholine system is also involved in form of thought disorder. We did studies with scopolamine and with mecamylamine, and I took it myself, in fact. And if you take it at quite a high dose, you end up talking talking rubbish, basically, not rubbish, but producing incoherent speech. And if you drink alcohol in a certain quantity, you also produce incoherent speech. So this is not only in the glutamatergic, but many systems are involved in form of thought disorder, and I think this is also one of the things we have to do research on with our discourse group. So in the last part, well, in the penultimate part, I will talk about genetics a little bit. Again, the glutamatergic system, and you see that there are some genes involved in the glutamatergic transmission, dysbindin, uregulin, G72. And we have looked at these genes and how they are involved in language production using a verbal fluency paradigm in the MRI scanner, verbal fluency in MRI in healthy controlled subjects. And in these healthy controlled subjects, we genotype them for dysbindin, G72, and uregulin. And then we compare those healthy subjects with the risk alleles as compared to the non-risk carriers during the verbal fluency task in the fMRI scanner. And what we very interestingly found is quite old stuff already, that we have the differential activation in language networks. Temporal areas, anterior cingulate, Wernicke speech area, and most strikingly in the uregulin subjects where we have differential activation in Broca's area and Wernicke's area, when we compare the risk versus the non-risk carriers in these glutamatergic pathway genes. This is a candidate approach. There are other novel approaches, again with Lena here, where they used a pathway analysis in the FOXP2 gene using in drug-naive schizophrenia samples, a sample, and looking at connectivity, and they found some, well, correlations between polygenic risk score and functional connectivity in these patients. It didn't reach, Lena, correct me if I'm wrong, it wasn't significant, but there was a strong suggestion of a correlation between the genes and the connectivity. I want to show you just this as a way forward, to not look at single genes, but using polygenic risk scores and combine this with imaging studies. So I think we know quite a lot about the pathogenesis of form of thought disorder. We know some risk genes. We know the transmitter system. We know the areas involved. And of course, we can measure the psychopathology with different scales. The last thing I want to show you is that this seems not to be specific to schizophrenia, but seems to be specific to form of thought disorder. And it doesn't really matter what the diagnosis is. And I think this is, again, the way forward is that we should not stick to schizophrenia, but we should widen our perspective to other diagnoses. And I'll show you some evidence now in the last 3 slides. We have in the last 7 or 8 years collected a huge sample, almost 3,000 subjects with major depression, bipolar disorder, and schizophrenia, and healthy control subjects. We have collected, we have deeply phenotyped this huge group of subjects using different psychopathology measures, a neuropsychology test battery, risk factors, early risk factors and current risk factors, protective factors, different scales. We have blood and stool, general data, lots of general data. So that's about 6 or 7 hours of interview per subject. And we have Fmri and MRI data, and we have GWAS, genetic data on them. We have followed them up. We have 1,700 subjects now. It's ongoing, and we now are in the process of doing a 5-year follow-up study where we again have collected and still collecting all this data from all these subjects. A very rich data set. And we also have, and the postdoc from our group, Friederike Stein, has been doing this. From 400 of these subjects, we also have natural speech recorded from them that is being analyzed at the moment. And if you're interested in this data, in all of this data, give me a call or write me an email. It's so much data that we are very happy to share this data with with anybody who is interested in that. And we are sharing this data already. We are in the Enigma consortium. We are in the PGC consortium, and we have collaborations with lots of groups with this data. So please contact me when you're interested in using this data. We have 250 publications on this data. So it's a very, very, very rich data set, and it's ongoing. Yes, so Friederike Stein, and this is being published this year, has taken more than 700 patients, major depression, bipolar disorder, schizophrenia, schizoaffective disorder, used these psychopathological scales, Hamilton Depression Rating Scale, Young Mania Rating Scale, the SAPS and the SANS, and did a factor analysis on these psychopathology scale. And she found 7 psychological factors across these disorders: depression, negative symptoms, delusion, positive form of thought disorder. This is what we are interested in: hallucination factor, mania, and appetite. And she found, and then she used these factors and correlated these factors with the cortical, with a volume, with a VBM, doing a VBM study. And what she found is that positive form of thought disorder factor correlates with a region in the inferior frontal lobe and in the temporal parietal junction here. So this is part of Wernicke's speech area, Broca's area here, and this is part of Wernicke's speech area, which is smaller in those patients, or it correlates negatively with the amount of positive form of thought disorder here. We also have here the medial temporal lobe, hippocampus here, and the bits of a basal ganglia here. And now the very interesting thing comes, which I found very striking and which was surprising for me, in fact, is if you take the cortical volumes, for example, from this area, but you can take any of these, and plot the volumes here according to the diagnosis. Here, major depression, bipolar disorder, schizoaffective disorder, and schizophrenia, you see no difference. So it does not depend on the diagnosis the patients have, but it depends on the form of thought disorder symptoms they exhibit, whether these areas are smaller or not, or they correlate with the psychopathology. And I found this very striking. And I think this is again one thing we should consider in the field to widen our approach to diagnosis other than schizophrenia, and look at other diagnoses. I will show you more examples. Again, Friederike Stein, who will give a presentation on the CIRS conference that has been advertised by Natalia and being organized by Lina, the CIRS conference in Florence next year. She will show you this data in more detail. What she did is she used the subs and sons thought disorder items, that's these here, in more than 1,000 of our patients, and did a factor analysis in the subs and sons former thought disorder symptoms. And she found 3 factors: a verbosity factor with these symptoms, a emptiness factor with poverty of content of speech and poverty of speech, and a disorganization factor with incoherence and distractibility. She did a explorative factor analysis and then confirmed these factors in the second half of the sample, and has a good fit. And then she again looked at the brain regions, gray matter volume, correlating with these factors, and she found a negative correlation between the verbosity factor, this factor here, verbosity factor, in parts of, well, Wernicke's area here in the left hemisphere, and the hippocampus, again the hippocampus in the left hemisphere. And this is independent of the diagnosis. Independent of the diagnosis. We can do statistics on that. And then she looked at the DTI, white matter fiber tracts, and found with the verbosity factor, again here, something in the white matter of the superior temporal gyrus here, a positive correlation of verbosity, and something here in the with this disorganization factor here in the basal ganglia. Again, this is independent of diagnosis. And now the last slide, the last result. This is not being published, but we are writing this up at the moment. Again, looking at the connectivity, the overall connectivity within the brain using DTI data, but now a structural connectome network analysis using 120 brain areas and calculating the strength of connectivity across these 120 brain areas with each other, and then correlating again this with more than 800 subjects here across diagnoses, different diagnoses again, and then correlating these connectivity matrix basically with these form of thought disorder factors. Here verbosity and here emptiness. And then you can come up with these nice graphs here. I don't want to really go into detail, but what I want to show you today, again, is that, well, here is the, here on the y-axis is a connectivity measure basically here. And here is the form of thought disorder factor here. And again, you see a negative correlation with the form of thought disorder factor verbosity and also with emptiness down here. So the higher the factor is, so the more psychopathology the patient has, the less connectivity you find, negative correlation. But the striking thing again is that this is independent of the diagnosis here. So this is not statistically significant between the diagnosis, and the same you find here. It's even more striking here. So the green dots are major depression patients, the red dots are schizophrenia, and the yellow ones are those with bipolar disorder. And you see no difference in the diagnosis, I mean. But it depends all on the psychopathology. So why is this? So let me come to my last slides. The brain is not organized according to diagnosis. This is somewhat artificial. The brain is rather organized according to functional networks. Functional networks such as a language network, a motor network, memory, social cognition, emotion, and so on and so on. And when you get a disruption of this network, well, it depends on what network is disrupted, what psychopathology you get. So if the language network is disrupted, you get language symptoms. If the motor system network is disrupted, you get a motor system disruption, and so on and so on. This is not a new idea. This is very old. This stems from Karl Wernicke from Breslau, which is now in Poland, who said that the disconnectivity of the brain area is the basis of the psychopathological symptoms. And if you look at the development of the brain, this is the age of humans, and these are, well, different projections and arborizations and neural migration, the development of the different neural systems in the brain. For example, this is the development of the red system here. I'm making this up just to show you. So the red system here, the red network develops like that, but the blue network would develop a little bit different. And so it depends on the genes and the environmental influences, what network is being disrupted at what time. In the end, and this results in the brain system that it's being disrupted, and then this results in particular psychopathological symptoms, which are independent of the diagnosis. And this is one of the main messages I want to convey today. So, what is the future of neuroimaging in form of thought disorder? We need deeply phenotyped cohorts followed over time in large samples across diagnosis, and then we can look at the etiology, the pathogenesis, and neurodevelopmental aspects, and do gene environment for language, thought disorder, brain interactions. We have to look in more detail into the neurocorrelates, correlates of the cognitive, emotional, social, linguistic domains. We have to look in more detail into single symptoms or single psychological factors of form of thought disorder, to multimodal imaging such as EEG, Fmri. We have to look at treatments. There are hardly any studies on that. I think none, in fact, but correct me if I'm wrong. I think it's very exciting to look at the automatic linguistic analysis and correlate this with brain findings and do much more pharmacological challenges, not only in the glutamatergic system, but also other brain systems. To sum up, all the basis is to have a good descriptive psychopathology. This is the basis of everything. We have to do this very, very carefully, using the TALT or Peter Little scale or other scales. I've shown you that the left and the right hemispheric language networks are structurally and functionally involved in form of thought disorder. I've shown you data on the glutamatergic system and the genetics of the glutamatergic system, but other systems are involved. And I've shown you that the brain correlates of form of thought disorder are independent of the particular diagnosis. And with that, I want to close and want to thank my colleagues here from Marburg and from many other sites in Germany and in other countries. And I want to thank you for listening and for staying here and for listening and for doing all this fantastic research on language, speech, communication, form of thought disorder in our patients. And I want to thank also the patients participating in these studies. And I'm very happy now to listen to Lena and then to discuss these and other findings. Thank you.
Thank you very much, Thilo. That was fantastic. And I think you captured everyone. Just like the symptom capture you mentioned, this was a capture of the audience. Thank you very much for your nice talk. I have just one slide to bring up to kickstart the discussion. You've nicely summarized the long body of work starting from Martha Shenton's times, the initial 1992 work, temporal lobe work. So let me bring up my slide and see if I can kickstart some discussion. So a lot has been done. Can you see my slide? Yeah. Yeah. Okay. So a lot has been done on trying to understand, discover the neural correlates of formal thought disorder, as Thilo rightly pointed out. Multiple modalities, multiple methods of examination has been used. And multiple different samples have been studied. It's impressive to see large samples coming up now from longitudinal data. The one that you showed with Frederick Stein's work is very impressive. But still, if you ask the question, what are neural correlates of formal thought disorder? We're still left with not a very clear answer. We're very excited by some of these signals, but it's not very clear what we can say as a neural correlate of formal thought disorder. And this is not just only a formal thought disorder problem. I think this is an issue with many symptoms that we study. So, you know, a general reflection of some of the issues, including issues that you pointed out already, is a small sample problem. We need to get away from it if we are trying to do correlation between symptoms and brain imaging measures. So that's already discussed in detail, so I'm not going to elaborate more on that. But the second issue, which you rightly pointed out, Thilo, is we have to really be more precise in how we measure what we measure, improving the scales that we use to measure. But there is a bit of an elephant in the room problem here. So the scales that we have, we try to quantify the experience of thought disorder, subjective or objective, using some sort of rating. And that rating generally comes from many different things. The higher you rate a symptom, the higher rating could be because the symptom is experienced more frequently, or it could be because there's more dysfunction associated with the symptom, or it could be because the symptom has been pervasive. We often don't separate these three dimensions very well in most of our rating scales. Circumstantiality, score of 1, score of 7 may differ. In all of these are just one of these, but still we rate them. And we try to reflect that in brain imaging and try to study correlations of that. Now that's a challenge. What do current scales of severity really reflect is very unclear for us. And perhaps some of the computational psychopathology approaches may be helpful for us to refine this more as we move along. The other issue which you alluded to is the issue of treatment response. Now, you know, we have this contrasting picture and longitudinal trajectory of thought disorder. A lot has been written about this. Positive thought disorder tends to mellow down, at least in some people over time, but negative thought disorder seems to tonically increase in some of our patients. Now, what are the correlates of this change as such is very unclear, because a lot of neurological correlates we know so far do not have similar distinct trajectories, or we don't know what those trajectories are yet. So, you know, what are the determinants of these longitudinal changes? To put it in other words, what causes resolution of thought disorder? We just don't know that yet. And I think it's an important question to ask as well. The other issues I have are general limitations, really, limits of causal inferences from imaging correlates. unlike some other symptoms and experiences where we can provoke them, you can do a symptom provocation test for mood, for example. You can do a provocation analysis for a lot of other things, including hallucinations. But it's not very easy to do provocation of formal thought disorder. What is the best experimental provocation of elements of formal thought disorder? You mentioned ketamine. Is ketamine's FTD similar or same or identical in any way to schizophrenia-related FTD is another question. There's a lot of overlap, but there may be elements which are different as well, and we need to really study that in more detail. The other issue is symptom capture. It's overlapping with the previous problem that you highlighted. We cannot provoke very nicely, and we cannot time the neural events as well very well with many of our current methods. So how do we time lock the event that underlies an expression of formal thought disorder in neuroimaging studies? I think this is a very important and interesting question, and EEG, MEG as well may give some answers for this, but it also creates the two-body issue in the study of language problems. Almost all that we know about speech disturbances and their correlates are coming from a single person lying in the scanner, for example, or with an EEG, electrodes on the head, for example, and producing words or responding to something. So there's no dialogical studies. There's no two people talking and then understanding. And there's a lot of issues in terms of generalizing what a person reads or understands from a text to how a person speaks in a social setting. So those issues have to be also addressed, I think, as we move forward. And the huge problem we have is we don't have good animal models of our object of inquiry, and this is a big issue. And that also raises a challenge for us, an opportunity for us. What can we learn from motor readouts from animals? And there's quite a lot to say about motor problems and how they are very overlapping and similar to speech problems in general. The most extreme form of negative thought disorder is catatonic lack of speech expression in some sense. So, can we actually study these things together? And what can we learn from catatonia and related animal models of catatonia? That's going to be an important focus. And from the work that you showed, Thilo, as well as everything that's been done so far, there is a huge absence of maturational focus of neuroimaging studies. We almost know nothing about the neural correlates of developmental deviations that lead to FTD. In other words, we don't know how language starts to derail early on in our patients with schizophrenia. We know, for now, we know quite a lot of data suggesting that disorganization in prodromal phase is a predictor of many different things in the future, including onset of psychosis, including worse prognosis, hospitalization, relapses, and everything. But that deviation, which happens many months, years before a proper diagnosis of any mental disorder could be made, is not fully studied. So we don't know what are the neural correlates of that deviation and when to start exploring that as well. So these are some of the points I thought I would raise on discussion. I will pull these slides off and I'll open it to everyone else to participate. Thilo, you could, if you have some thoughts on this, you can start with responding, and then we can have others.
Yeah, thanks, Lena, for expanding this and raising this issue. I totally agree with you. 100%. Well, there is still so much we don't know. And particularly this the developmental aspect, I think you touched upon. There is surprisingly little that at least I found in the literature about neural language development that would be very important for us studying language problems in our patients. If we had these trajectories in children, particularly then leading to at-risk states, I think this would be very, very interesting. So I think some people among those who are here now present have started language in at-risk subjects, also using this automatic speech analysis. I think this would be also really the first step forward, since we can't, study children. The other aspect you touched upon is negative form of thought disorder that I somehow, excluded because it would be just too much. It's very little. It's being studied very little, in fact. And as you said, I think this is also very important because this negative form of thought disorder correlates a lot with negative symptoms, and they have a very bad, a very a bad course. A trajectory, very bad social functioning outcome. Yeah, again, I fully agree, but I don't want to talk too much now because I've been talking. So I think there are many competent people who have done their own fantastic studies in this field, and I would be very happy to enter a discussion amongst us and not among me and you, but also include all the other specialists in the field. They are, I think, as competent as myself are.
Thanks to them. Dalia, are you going to take the questions and moderate them?
Yes, we have some questions. I think Professor Peter Lido, maybe he wants to take the microphone and to ask.
Good. Okay. Thanks, Natalia, and thanks Thilo for a wonderful presentation. I've put a short version of my question in the chat, and I'll try to keep it pretty short. But I want to expand into one of the issues that Lena also put on the table, and that is, this transdiagnosis issue. First of all, I have a lot of sympathy with the notion of a continuum between schizophrenia and bipolar disorder, and indeed a psychosis spectrum. However, I guess if we go back to what Kraepelin regarded was the really important thing, I think it was time course that he emphasized as important. Bipolar is, broadly speaking, episodic, and schizophrenia is episodes superimposed upon persisting symptoms or disability. And so in that regard, I'm very interested in the distinction between transient versus persistent thought disorder. And just before I let you tackle that, which is the main question, with regard to genes and positive thought disorder and negative thought disorder, there's a very interesting study just published a month ago about polygenic risk factor predicting disorganization disorganization in schizophrenia. They say that the strongest feature predicted by the polygenic risk score in their analysis is disorganization, which includes formal thought disorder and inappropriate affect. But in addition, they do show that it predicts what they call expressive negative symptoms, which include alogia. So in other words, none of their big study is that polygenic risk score most strongly predicts disorganization most strongly, and a bit less strongly, but nonetheless importantly, alogia and blunted affect was the other one in there. So I see that as two very close related items, namely the relationship between the alogia and the positive thought disorder and the genes, and the relationship between acute and transient. So I've wrapped a number of issues up together, but I see them closely related. So any comments on any of those relationships, but particularly the persistent versus transient distinction with regard to the transdiagnostic question?
Yeah, thanks, Peter. So in the data I've shown you is that this is a cross-sectional data set. We haven't looked at the longitudinal data. We are doing this now, the 2-year longitudinal data. So this is a cross-sectional data. So I can't really tell you that. We also have done the OPCRIT, which captures lifetime psychopathology. But here the problem was or is that in the that patients, they don't remember whether they had a problem with form of thought disorder in the past. They remember hearing voices, or they remember a manic or depressive episode, but not form of thought disorder. So this is why the OPCRIT doesn't capture form of thought disorder, and we do not have clinical records from all of these, to 1,500 patients, but just a few of them. And if you don't have the clinical record with the psychopathology written in it, we don't have this. So, but we will have it in a couple of months. And I can tell you more about that. But true, there are patients that with schizophrenia, they have chronic positive or negative form of thought disorder, and then there are other patients that have only a episodic core, similar to what you alluded to, the manic patients with mania. But very interesting subject. I don't have an answer.
Good. Thanks very much. And indeed, I don't think any of us do. Interestingly, the best data set I had presented in my talk many weeks ago, which is from the pre-antipsychotic era, and it's the Phone and Winnaker study. But I won't go into that because I described it all in this meeting a couple of months ago. That was a wonderful 35-year duration study with very detailed psychopathology. We just don't do that anymore, but I totally endorse your emphasis on the need to record this and the need for the longitudinality. So once again, thanks for a very exciting presentation, and we look forward to further explorations of these things.
Great. The next question comes from Sebastian Wota. If you wanted to speak aloud, feel free. He says, thank you for the fantastic talk. Given the potential involvement of glutamatergic system, is anyone aware of studies showing that clozapine was particularly helpful in treating the formal thought disorders? Anyone?
I am not. That's why I'm asking the question.
Okay.
I know of a study that we are participating in. It's being conducted by Komiet Hassan from Augsburg. And this is a clinical study looking at early schizophrenia within the first year who do not respond to the usual antipsychotics, and they are being switched to clozapine. And we are doing the TAL scale with these patients. So this might answer your question, but there are now, I think, 20 or 30 patients only included in this placebo-controlled ongoing clinical study. It has nothing to do with brain imaging, just symptom. That's the only one I know, but others might know more than I do.
I think there's some evidence linking, indirect evidence linking disorganization to treatment resistance, and that would somehow suggest that clozapine could then be more effective, but no direct evidence that I know of.
Can I point out that 30 years ago, Herbert Meltzer published a paper in which he said clozapine was effective for disorganization, but that was in the earliest days of us getting excited about clozapine. And I'm sure that, well, we should do that sort of work carefully again.
Okay, great. Next question, Natalia Jimeno. She's firstly, she thanks for the interesting presentation. Natalia, if you wanted to open up your microphone, please feel free. Would this, please. Oh, we cannot hear you. Sorry, your audio is not. Oh, so sorry. I will read it aloud. Would this transdiagnostic model of formal thought disorders also useful for other dimensions? Great question.
Yes, of course. We found the same for other dimensions such as depression and delusions. So I just focused on the formal thought disorder because this was the topic, but it's the same for the other psychopathological dimensions. So this was seven dimensions, and it's true for all of these dimensions that they are independent of the diagnosis. We know that many patients with schizophrenia, that, for example, they have depressive symptomatology. So the same brain areas in depressive syndrome and schizophrenia are involved as they are involved in depression. Very roughly, though. Yes. So the answer is yes.
Great. The next question is from Wolfram. Wolfram, do you want to ask a question?
Yes. So as I say in the comment, I was really very grateful for this talk. I've never seen such a survey from the earliest days to really contemporary research. I basically have a very simple conceptual question and then a technical one. And the conceptual question I would like to put in very simple terms. There are some people in cognitive neuroscience who really strongly believe that language is distinct from thought in the brain. So they correspond to different brain systems. And I think that matters to us because in psychiatry, we are interested in the disorganization of thought. But then when we study that, it is language, which is all over the place. Ultimately, this is what we are looking at, behaviorally, as well as at the level of the brain. And so basically, I'm asking you, what is your thinking, if you have any thoughts on that, for what the work that you have showed us implies for the relation between language and thought? Should we still think that these are distinct systems, or is what formal thought disorder tells us that they are closely related and maybe even identical? And the technical question has to do with the scanning of in-scanner productive speech, because you seem to be one of the pioneers in this domain, and many people shun away from doing that. So I'm just interested in how you overcame the technical difficulties associated to that.
Yeah, thank you for this two very important questions. The first one is a philosophical question, I think, because it can't be answered empirically. You know, I can give you my personal opinion, but I don't think I'm you know, whether thought and language, what you ask, what is the relation between thought and language, thought and speech? So we have to consciousness and language. I think I think it's an artificial separation that we do, you know, that humans do, that they separate thinking and language. You can think without language, and we all know that we all think without language. For example, when we write a paper, we have an idea in our mind how this paragraph should, what idea the sentence or the paragraph should convey in the end, a rough idea. And then we write it down, and then we read it again, and then we think, ah, no, this is not really what I wanted to say. And then we rewrite it, and then it comes closer, and then we rewrite it again and again. And then this really captures what we were thinking. So I think there is a pre-linguistic thought, even pretty complex, in fact, pretty complex ideas in our mind that have not been put into language, but that are there, complex concepts without language. But, you know, it's my personal opinion. And, you know, we can see it from our patients that they have this. I think Peter Little was giving a presentation on that, on disorganization and on language and how this relates. And I think this captures it, that we have disorganization and we have disorganized language. This can separate, but usually it goes together very closely, is what we see in our patients. And yeah, but I'm sure we can open a discussion on that, and there are other ideas, because I don't want to talk. It's only not me who want to talk. The other question you had is about the technical issue. You know, we're just doing it. We have people lying in the scanner. We fixate the head as good as we can, and we let them talk in the scanner. And then we measure the brain movement, and we exclude those who move too much. It's not that many, you know, it's 1 or 2 within 20 subjects that have to be excluded. and then you do the analysis and it works, you know, it works fine. The problem is rather with the susceptibility artifacts by moving the head. So I'm not very convinced that we capture everything in the inferior temporal lobe and in the pre-genital cingulate while speaking. But there are, as you probably are aware of, that there are these possibilities in using particular sequences that can deal with this. Yeah, you know, you can you can have people talk a word for a word and then capture the bold effect after they have been speaking. You can somehow tweak the these areas with special gradient things. The physicists do that. Yeah, well, I can only tell you it works, but it's not perfect in the inferior frontal lobe. But you know, let's open the discussion about language and thought and cognition. There might be other ideas on that from other people, please. So what are other opinions or what are other responses to this fundamental question?
Well, I mean, some people in neurolinguistics, Evelina Fedorenko, for example, is maybe the most prominent. She has literally written a paper saying language and thought are not the same thing, and she has empirical reasons for that. So it's not really a philosophical view. But I think in psychiatry, if you want to cook up a theory of formal thought disorder, it is something we have to think about. And you made the point about pre-linguistic thought that predates language production. But that's really a point about a kind of thought indeed predating speech or speech production. That doesn't mean that this form of pre-linguistic thinking is independent of language, if you want to make a distinction between language and speech. Speech being the externalization in a physical channel of a linguistic process. So I think for a theory of FTD, what we really have to think about is how not speech, but language as a cognitive system is distinct from the kind of thinking we are interested in as psychiatrists.
Well, there are a few more questions, but I just wanted to add one thing to this line of thinking. I think we cannot solve how we differentiate thought and language in this discussion. That's a big undertaking. But one thing that seems valuable to me in our research paradigms in psychosis is trying to treat thought disorder as more of a trite phenomena and language problem as more of a state phenomena, and try to capture resting correlates of outside the scanner measurements as well as in-scanner language measurements. And it's not going to solve the problem, but it'll give you something extra for us to, you know, parse and play with.
Okay, next question from Sunny. Please feel free, Sunny.
Great, thank you. And thank you for the talk. So I think my question is actually a little bit of an extension of the first one that Peter Little asked. So I've noticed that, so not only I think can formal thought disorder symptoms vary across illness course, I've noticed that they can even like vary pretty significantly minute to minute, I think, with some patients. I've certainly, I think many clinicians have had the experience of speaking to a patient thinking that they're rather well organized for a few minutes, and then suddenly they, you know, totally derail. I was thinking to myself, I mean, I assume that brain structure is not changing from moment to moment, but I wonder if there are functional brain changes, networks, or changes, perhaps maybe some, you know, in terms, a bit in terms of neurotransmitter systems that might reflect this moment to moment phenomenon. And I was also wondering if we really have the clinical measurement capability to detect this kind of variability.
Yeah, thanks very much. We know this when we talk about everyday subjects. Patient is totally coherent, and then we go into the delusional system, and then patient goes way off. So if it has a very strong emotional content, what we are talking about, then patients often start to derail. Yes, This is what we see on a daily basis. So what you were asking is if you can capture this fluctuating across time. This is what I have been showing with these with the in the Fmri study we did in 2001, and this has been also been done in the PET study from 1998. Phil McGuire is the first author, where in the PET study they used 3-minute epoch blocks of speech, and in the Fmri study we used 20-second epoch blocks of speech. And then we took these 20-second epochs. Well, patient is lying in the scanner, talking continuously. We measure brain activation. We record the speech. We transcribe the speech. Then we rate the amount of positive form of thought disorder. Peter Little did that with the TLI scale. And then we give each 20-second epoch a rating of form of thought disorder. So each gets a number, 20-second number, form of thought disorder is 3. Then the next one is 2, then the next one is 8, then the next one is 10, and so on. So this goes on across 6 minutes in the study I did. So you have this fluctuation across time, and then you take this fluctuation across time and correlate this with brain activation. And then what you get is the Wernicke speech area. So when the patient talks form of thought disorder, a high form of thought, positive form of thought disorder, Wernicke's area is being downregulated. When the patient talks coherently, Wernicke's area is being upregulated. This is what we saw in these two old studies from 20 years ago. And this is exactly what you were describing.
That's fascinating. Thank you.
Mm-hmm.
Thanks for that. Well, Natalia had to go, so I'm taking over moderating from her. There are a few more questions. We have Kiran Bagali from India. Kiran, are you online? You can ask your question if you're online.
Hi, sir. Thank you for the presentation. So, sir, my question was in individuals who are bilinguals or multilinguals. So, and who have schizophrenia, while we do imaging studies, how important is it to control for number of language spoken? Because there are studies which say that the brain responds differently between monolinguals and multilinguals. So how important is that?
Good point. As far as I know, these studies in patients have all been done in native speakers. I don't think, but please correct me, anybody, that there are studies in bilinguals, patients who are bilingual and formerly thought disordered. I haven't seen that, but I might not be aware of. Well, I can't really answer your question because I don't know. Of course, we know that there are differences in fluent bilingual healthy controlled subjects regarding their language areas. But I don't know how this extends to patients really. There are these studies with patients who have a tumor in language areas or a stroke, ischemia, who then can only talk in the one language but not in the other, or vice versa. All sorts of things have been described. But is anybody aware of any schizophrenia study in that in the audience? Yeah, so I think, if we do Fmri, MRI studies, we should control for that, for true bilingualism. We're not talking about a second language like, myself. I don't think this makes so much difference, but true bilinguals who were raised with two languages, I think this makes a difference in the brain, in the language areas.
Tangentially, I've seen some studies showing that people with schizophrenia are equally able to acquire a second language and become proficient in it as people without schizophrenia, that they seem to have a preserved ability to develop further languages.
Yes, I wouldn't doubt that. But if you look at the brain, you have I think more for true bilingualism. If you look at language studies, yes.
Thank you for that. We have questions from Fmri Bora, Wenjun Su, and also Gina Kuperberg having some comments to make. So we'll go to Wenjun Su. Wenjun, are you online?
Yeah. Thank you, Professor. So I have a very quick question. Is that have you ever considered using the STG as a treatment target for other physical therapies such as RTMS or TACS, etc. for FTD?
Excellent question. You know, we have been thinking about this for decades, really, but haven't done it. I know there are these studies on hallucinations. Has anybody done that in the audience? TMS with thought disorder.
So Iris has done a lot of Iris Sommer has done a lot of work on hallucination TMS.
Yes, hallucinations.
She's
Yes.
in the audience, yeah.
And also the people from Bern and Zurich, they have done that. Iris Sommer, yes. But not on formal thought disorder. Has anybody done that? You know, we should do it right now.
Sebastian is in the audience. There may be some findings from motor IPL TMS for motor symptoms. There might be some observations on disorganization. I don't know if Sebastian, do you want to add anything to it? No? Okay. So we have Fmri Bora with the next question. Fmri.
Hi.
Hi, everyone. I will have two questions. One of them was specific to Thilo's talk and an example. I mean, when we are doing analysis such as factor analysis for concepts which are not clinical, it's quite fine to have mixed populations, but many clinical tools are not constructed for healthy populations. And I mean, it may be the fact that if we are studying a psychosis-related concept, but factor analysis conducted in a non-psychotic population, the findings might not be the same as in a originally intended population, and the brain correlates of these different factors might be different. One of my questions: do you think that this might explain some of the differences between your findings and other findings? Second one is in more general about transdiagnostic approach and dimensional approach in psychiatry, because they are getting more and more trendy nowadays. But they also come with their own weaknesses, in my opinion. That's all.
Yes, thank you. This was a comment, or was this a question for me or for anybody else? Because I didn't quite get it. So you were asking about dimensional versus categorical approaches.
Yeah, in general, yes, but also regarding your if you conduct factor analysis in a depression sample versus psychosis sample for a particular construct, the results might be different.
Yes. I mean, you yourself have been doing a lot of studies on that, and you're a very expert in that. Of course, you know, in the factor analysis, you know, you you get out what you put in. As it always is. So the factors, of course, depends on the population and depends on the scales you use. So these factors, they are somewhat specific for the population you apply them to, and they're also, of course, specific for the scales you use. So that's why in the studies from Federica, who is also here now today, we have applied this factor analysis on our sample and used these factors and correlated them with the brain structure. But of course, the factors would be different if we would have included only acute schizophrenia patients, or if we had only included chronic schizophrenia patients, and if we, yeah. So you're perfectly right. But I think our findings with this transdiagnostic sample is externally validated because we found these areas correlating with the psychopathological factors that other previous studies have been have found in within diagnostic samples. For example, the thought disorder findings in language area across the disorder, or the hallucination factor that we found is correlated again to language areas, or the delusion factor that we found is correlated very much to limbic areas. So I think there is some external validation to the findings that we had, but yeah. But you're right, factors depend on the population and on the scales.
Thanks for that, Thilo. It'd be nice to have some treatments that we can match to the categorical presence of FTD. We don't have that yet. Till then, I think dimensional quantification will be really useful for us to study the correlates in many ways. So I'm going to call Gina Cooperberg. It's nice to have Gina as likely our last question for today's session. Gina is going to also be the presenter next month, December the 17th. Please mark it if you don't have it already in your calendar. So over to you, Gina.
Gina, hi.
Hi, Thilo. Long time no see.
Yes.
We actually overlapped at the Institute of Psychiatry all those years ago, so I remember those studies. I have actually a comment, a question, which was stimulated by the previous question about the factor analysis. I have just a sort of general comment. My question about the previous comment was actually, there was one thing in your presentation that really struck me. It's great that you're sort of collecting such large samples now. And in one of your factor analyses, I think sort of the factors fell out. There was one which was you called disorganization, and the other one was something else, but on it loaded things like tangentiality and derailment. Yes. And I guess in my head, I'd always thought of disorganization, tangentiality and derailment as part of disorganization. So I was just curious about what distinguished what distinguished those two factors. I mean, because a factor analysis also depends on how many factors you want it to specify, right? So it depends on your model. And so I was just like, how do you distinguish disorganization from derailment, tangentiality? And it matters because in your later data, you basically showed that the latter, but not the former, was what correlated with all those other brain structures across disorders. So I was just curious about how you thought about that.
Yes, thank you, Gina. I thought about that, and I was thinking exactly the same as you did. Why are these two separate factors? Because these symptoms, they are so similar. Why do they load to another factor? And to be honest, I can't really tell you why this is. This is we took the data, we put it through the software, and this is what came out. And why this is, I'm not really 100% sure. Well, there is Friederike Stein also here present. So we also, of course, had a look at the fit of different factor solutions. So if there was 1 factor, 2, 3, 4, 5, 6, 7, I think up to 7. And the best fit was with these 3 factors. And if you use 2 or 4 or 5, it starts to become very, clinical, totally, irrelevant. And this was the best fit. And yeah, this was just the best fit. And Friederike, you are here.
My experience of doing factor analyses is not only about the best fit, it's also about face validity with the constructs you're actually interested in measuring. And so it might be worth looking. I mean, obviously it's picking up some variants, it's picking up something. So I'm just really curious about when you look more deeply at basically the underlying constructs, even if you just did a sort of cluster analysis and put the individual symptoms, it's picking up exactly what it's picking up on. And so it's just really interesting that it clustered that way, because it's not what I would have predicted or even put as a constraint in a factor analysis. So that was, that was interesting, especially because it's not like they both predicted the same thing in the longer term. So I know what's going on there. But the second,
do you have any comment on that, Friederike?
Yeah, so from the literature, what we see is that there seems to be consensus about one negative domain, but when we look into more detail, specifically for positive form of thought disorder, the solutions or the factor solutions of the studies highly differ. So there are studies showing 5 positive factors. We showed 2 positive factors. Some studies just show 1 factor. I think it highly depends on the measurement you use to assess form of thought disorder.
Right, but the irony is that the measurements that we use, like I've never done the PANS or the SAPS or trained anyone. I mean, every time you say, if someone's really got a lot of derailment and someone's got a really lot of tangentiality, then almost by definition, they have a lot of disorganization. So why would those intuitively correlate? That's how we're trained to do the scales themselves. So it's just kind of curious that why they fell into different factors. It must be that the disorganization one picked up on something else. And I'm just curious about what.
Peter has something to say.
Could I just chip in there? Because it goes back to the first question I asked. I mean, I would have predicted precisely what you found in a big transdiagnostic group. Acute, or at least the formal thought disorder that's common to bipolar and schizophrenia has tangentiality and derailment and the things that you called verbosity. But the things you called a disorganization were things like illogicality and the more classical schizophrenia type things. So I think it's not an artifact, it's a real phenomenon. When you put all the diagnoses in the 1 factor analysis, you get what you get. If you actually try to tease out what is characteristic of schizophrenia, or at least the case we call schizophrenia, we've already talked about a continuum. So, we're now getting into a multi-dimensional discussion. But what you observed is exactly what I would predict. So I was very pleased to see that. And I think the key is the difference between the transient, if you like, bipolar type tangentiality derailment and the persistent illogicality, peculiarity, oddity. So for what it's worth, I would have predicted that, and it still goes with that, the importance of that time domain, the persistence versus transience. Anyway, I'll leave it there.
That's really interesting. Okay, yeah, I'm sort of curious to know how you think about illogicality versus some of these other phenomena, but I guess yeah, we can talk more offline about that. Actually, the transience is something that this was more just a general comment. So we know that language is extraordinarily fast. Every single word that we say is related to every single other. So even in the 30-second or 20-second or epoch, that's huge compared to the timescale at which the brain is basically able to plan the next upcoming word, and the timescale at which something like tangentiality, perhaps not, as Peter's sort of implying, a sort of a logical frame of thought, I have no idea, but it's certainly a very, very different timescale to one that we're able to measure with fMRI. And so I often think that what we're measuring is someone who used to do a lot of fMRI, but has sort of become a little bit disillusioned with the technique just simply because it is just so slow. And it's picking up a kind of downstream effect of multiple kind of issues. And we're not able really to pick up using this technique of the actual cause, the actual mechanism by which people produce or comprehend speech online, in other words, word by word. And I guess that kind of makes me, like, there was one thing that Lena put up on his slide. If we're really truly interested in symptom capture rather than just describing the effect of producing disorganized language, then I think we really need to kind of think very carefully about techniques that are able to capture that kind of millisecond by millisecond mechanism, you know, in other words, and then you can still get lots of power by averaging across lots of words, but kind of, you know, I mean, like, you know, your talk was so, it was very broad and beautiful in terms of taking us through, and I think anyone watching this would be convinced that, yeah, somehow language, many regions that we know involved in language processing are involved and play a role in schizophrenia as well as other disorders. And that's just so important because so many people don't think about language when they think about these disorders at all. So that's like a huge kind of important point. But then, you know, if you were sort of being a skeptic, you could then say, well, okay, you've shown us that people who speak abnormally have abnormal language. Well, of course, how could it be any other way? And so to be able to really nail down mechanism, I just keep kind of racking my brains about how we're going to actually kind of figure out why this is happening. And I just, you know, someone who sort of thinks about language, I just think that we can't ignore the fact that by its very nature, language is so sequential and so fast and so online, and we need methods to be able to capture what's happening just before, during, and just after each word, you know, to be able to really get a handle on what's going on and sort of capture the kind of timescales and do true symptom capture. So I just wondered, I mean, do you think that, yeah, I'm just interested in, other people's sort of thoughts about that. And I keep going to and fro because I think, you know, on the one hand, we need that, but on the other hand, these methods are showing us something. But then, as you sort of rightly said, hypo, it's not really telling us about mechanism. It's not telling us about why. So I'm just curious about how, you know, as someone who I know from way back who sort of thinks deeply about these things too, I just wondered whether you had any comments on that, Thilo, or anyone else.
Yeah, thanks, Gina. Of course, I mean, you are 100% right. One technique would be EEG, of course. You've been doing that a lot. Other people have been doing that a lot. And I was alluding to the pathophysiology and also to continue doing very sophisticated minute paradigms to tease apart what you call mechanisms of language. I think this is you know, we have to approach this phenomenon from many different times. The one is, you know, big data, doing genetics and blood and imaging, across disorders. The other is having a hypothesis, selecting a very narrow selected group of patients, of people, doing very sophisticated paradigm, having super high temporal resolution. You know, we need all of that. I haven't been talking about that because I'm not a specialist on, you know, EEG. We have done a little bit of event-related stuff, but not so much. And I was you know, looking at the fMRI and MRI data on that. So, but you know, you're totally right. We need all of that, and we need clinical observations and observing patients and looking at symptoms very carefully. Also, not forget that. Yes. So thank you.
Yeah. Sometimes I wish we didn't have to choose so much. I wish that we could kind of all get to. I wish that we could do large-scale studies using kind of more sophisticated paradigms. But you're right, it does tend to be a sort of, you have to choose. And I sometimes wonder why that is, but maybe it's just the way the field goes.
I wish this can go on, but unfortunately we have to close. Gina, I'm sorry for being the person who closes this interesting discussion. But the great news for everyone here in the audience is Gina is talking next month to us, and I'm sure you will continue with some of these issues as well, Gina. This is December 17th, so please make a note. And I want to close by thanking you, Thilo, for a fantastic 2-hour engagement. You mentioned to me that Friday afternoons are generally family time for you. You've given up some of your family time for all of us, and that's really fantastic. Thanks for being here. I also wanted to again remind everyone of the generous mention you made to the large database that you have. You are open for people to approach you and use that data they want to study, and that's fantastic. And that's really the spirit of our consortia. So thank you very much, Thilo. And please reach out to Thilo if you're interested in that data set. I also want to make 3 very quick announcements before we close. Number 1 is the special issue that we are bringing on behalf of the Discourse Consortia and Schizophrenia Bulletin. There is an extension. Please send your abstracts by end of December 31, if possible, to myself, Eric Tan, or Iris Sommer. And then the full paper can be submitted by March 31st. So please note that. Number 2 is Natalia and Eric will be coordinating an early career researcher symposia next year, series of seminars like this next year, largely from early career researchers involved in the Discourse Consortia and people interested in studying language and thought. And again, we will be diverse, multidisciplinary. We'll have computational, psychopathological, imaging, and EEG, and all sorts, and linguistics, of course. So if anyone is willing to present and have interesting data, please reach out to Natalia Mora or myself or Eric Tan. We are looking for these series to start after the SIRS seminar in April. So we're hoping for May, June, July as the time for the next start. Third one is, well, I mentioned this again already, so reminder, next talk is December 17th, the week before Christmas. So please be here, the same room, same password, very likely same people. Thank you very much, everyone. Thanks again, Thilo. See you all.